225047. We're good. You can go to the next one. Everybody pretty much knows all that.
Okay.
If everybody would, I think that you're already muted as you come on, but if you could stay muted until the end. Also, if you can be attentive and engaged in the session. We also ask that you complete the evaluation at the end of the presentation. I'll put the link in the chat box for everybody. And so this is the South Texas Family Medicine Grand Rounds. It is brought to you by our educational partner, the South Central Area Health Education Center, the South Central AHEC. And our mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. So in order to access your CME transcript, you can visit the CME website listed there. You can also print your transcript, but if you have any questions, the address, the email address, and the phone number are listed there. You're welcome to reach out to them. Also for AAFP members, you are able to claim credit for that. So if you have any questions, you can contact me, or the phone numbers are listed there for the AAFP as well as their email address. And today we have the top poems of 2019. Bedtime hypertension treatment improves cardiovascular risk reduction. So we have Hannah, Dr. Hannah Korman, presenting today with her faculty mentor, Dr. Siddiqui. And then I think the next slide probably says that they have no financial interest to disclose, and I'll let her go ahead and take it away.
Okay, thank you, Nicole. Can everyone hear me okay? Assuming yes. Okay. My name is Hannah Korman. I'm a third-year family and community medicine resident. Thank you all for having me for today's Grand Rounds. Like Nicole said, we'll be discussing one of the top poems of 2019. So for those of you who don't know, the poems are selected by the AAFP. They are patient-oriented evidence that matters. And my topic is discussing bedtime hypertensive treatments and how that affects risk reduction in cardiovascular morbidity and mortality. Okay. So just as an overview of what we'll be doing today, we'll be discussing the relationship between circadian physiology and RAST physiology. We'll discuss how we can use the circadian rhythm to optimize our treatment outcomes, and we'll also discuss the safety and efficacy of different methods of administering antihypertensive medications. So for the uninitiated and for the initiated, I wanted to throw us back to the RAST system just as a reminder. So initially, the kidneys sense drops in blood pressure, drops in fluid volume, which stimulates the kidneys to release renin. Renin converts angiotensinogen from the liver to angiotensin 1. Angiotensin 1 is then converted by ACE to angiotensin 2. Angiotensin 2 acts on blood vessels directly to cause vasoconstriction and therefore increases in blood pressure. Angiotensin 2 also acts on the adrenal gland to stimulate the release of aldosterone, and aldosterone acts on the kidneys to stimulate a reabsorption of sodium and water. So basically, in short, when your body senses that you have less fluid volume and lower blood pressure, there's a cascade called the RAST system that acts to bring your blood pressure back up and bring your fluid volume back up. And looking at this physiology, you may recognize many of our current medications and treatments for blood pressure act directly on this system. So for instance, we have ACE inhibitors, which inhibit the ACE enzyme in the lungs, so angiotensin 1 can't be converted to angiotensin 2. We have aldosterone antagonists, such as spironolactone, which inhibits aldosterone and prevents that sodium and water reabsorption. We have calcium channel blockers that act directly on vessels that inhibit their vasoconstriction. So the RAST system is really what decides our blood pressure. And going on into the circadian rhythm, I think we all understand sort of colloquially what we mean by the circadian rhythm, but I wanted to formally define it before we go forward. This is the natural internal process that regulates the sleep-wake cycle and repeats roughly every 24 hours. So our body works in the circadian rhythm. Our body temperature fluctuates in a 24-hour cycle. Our blood pressure changes in a 24-hour cycle. Our hormone secretion often works in a 24-hour cycle. For instance, on this, you'll see like melatonin, for instance, secretion works on a 24-hour cycle and repeats. Okay, so marrying the two. This is a paper from 1985 that sort of typifies and characterizes the relationship between circadian rhythm and RAST physiology. So let's see. If y'all can see my clicker, I'll just going through these charts. I just want to demonstrate some relationships here. On the top chart, you'll see these two lines. What they did is they took blood pressure measurements and blood samples on hypertensive and normotensive subjects. So for each chart, you'll see two lines. Those are for hypertensive and non-hypertensive, which isn't super relevant to what we're talking, what I'm trying to illuminate from this study, but just so you know. So this is the mean arterial blood pressure, and what you'll see is from 800 hours, so 8 a.m. to 800 hours the next day, you'll see the average decline in mean arterial pressure. There is a little bump later in the evening, but overall the mean arterial blood pressure does go down throughout the day and reaches a nadir at about 400 hours, about 4 o'clock in the morning, 600 hours, and then slowly before awakening, or very quickly before awakening at 600 hours, 800 hours, blood pressure, mean arterial blood pressure increases very sharply. And this is found to be consistent in most humans, that they have this decline in blood pressure throughout the day, and it reaches the lowest point at night and then rises in the morning. What we're looking at in this next chart is plasma norepinephrine levels. Follows a similar pattern to mean arterial blood pressure. So we have peak levels in this 800-hour region. It declines as we move throughout the day, reaches a nadir at about 400 hours and 600 hours, and then quickly begins to increase before awakening. What I wanted to really talk about, though, was and unfortunately is less well characterized and less obvious in this chart. However, the data does pull out that plasma renin secretion in this bottom chart has a similar pattern. So throughout the day in hypertensive and non-hypertensive subjects, it remains kind of flat. But what I want you to notice is that rather than reaching a nadir in the early morning hours, is that it increases. So what is postulated is happening is that in response to these perceived decreases in blood pressure, so these absolute decreases in mean arterial pressure, renin in secretion is enhanced. It continues to be enhanced until blood pressure starts to incline. And so renin secretions reach a peak in those early morning hours before awakening. So if we were trying to target the renin-angiotensin-aldosterone system in order to have an effect on blood pressure, it would make sense that we would want to target it when it's at its highest concentration. So this is to say in those early morning hours when it really is acting the most on our bodies. Okay. So like I had mentioned before, I just wanted to make a note. So we were talking about this decline in mean arterial blood pressure, and especially there's a big dip at about 2000, 2200. So sleep onset to a sleep average is about 10 to 20%. So you'll see in most people a 10 to 20% drop in blood pressure from average awake blood pressure versus average asleep time blood pressure. This is referred to as dipping status. It's a kind of antiquated term, so this chart kind of demonstrates it pretty well. Systolic, diastolic mean blood pressure, and all of those dropping while people in the sleeping hours. It was popular for a moment because it was thought to be a better predictor for cardiovascular morbidity and mortality than awake time or even office blood pressure measurements. But it's not super practical, and so it's not used. And there's also some complexity about it. So normal, like I said, is 10 to 20%, but people who have no dipping or can have increases in their blood pressure, there's almost always pathology associated with that. And in addition, average sleep time, systolic blood pressure, so just this top number here in the sleep time period is a better predictor than dipping status alone. Okay. So that brings us, so that's the background to my paper. So what we'll be discussing is how bedtime hypertension treatment can improve cardiovascular risk reduction. So the long and short of this paper, this study, is that it was a multi-center, randomized and controlled, prospective blinded endpoint trial with about 19,000 patients. So these patients were split into two arms. So 9,000, approximately 9,500 of them were asked to take their blood pressure medicine in the morning upon awakening, and the other half were asked to take them at night. The prescribers that these patients saw were not advised on what blood pressure medications to give. So whatever they thought was indicated, if they had certain comorbidities, they could prescribe whatever they chose. If they were taking more than one blood pressure medication, they were advised to shift all of their dosing to either all in the morning or all at night. There was no split dosing. The primary outcomes that were looked at in this study were MI, so heart attack, coronary revascularization, heart failure, stroke of either type, hemorrhagic or ischemic, and cardiovascular death. Just going more into the inclusion and exclusion criteria. So the population in question were Caucasian, Spanish, men and women greater than 18 years old. In order to participate in this study, they needed to adhere to regular daytime and nighttime routines. They also had to meet certain criteria to be diagnosed as hypertensive, and those numbers are there. Some exclusion criteria that I thought were interesting: pregnancy, secondary hypertensives, cardiovascular disease, CHF, AFib. And then one of the most important ones is if they work night shifts or had any shift work employment that would disturb their circadian rhythm, they were excluded from this trial. Okay, and how was the data collected? So they enrolled these patients and they followed up at minimum yearly. That at these yearly appointments, they would be set up with a 48-hour blood pressure monitor and advised to create a sleep-wake diary. So writing down when they went to bed, when they went to sleep. They were advised not to nap or not to disturb their sleep rhythm during these 48 hours. They were given an ambulatory blood pressure cuff that recorded their systolic and diastolic blood pressure plus their heart rate at the upper arm every 20 minutes during waking hours, and then every 30 minutes at night for 48 consecutive hours. So just 2 days straight of blood pressure monitoring almost continuously. Otherwise, they also had these patients come in during these 48 hours to collect blood and urine studies for analysis. And just so you, median follow-up, we'll talk about this a little more later, was about 6 years in both treatment arms. Okay, so these are baseline characteristics of the two arms of the trial. This is just to demonstrate that they are well randomized. So they were both approximately the same age, about 60 years. They had the same percentage, same sex distribution. Things that I want to make special note of are the percentage with CKD, the percentage of people with smoking and obesity. They're essentially the same. Other things to make note of is that their serum creatinine measures were essentially almost identical, at least not significantly different between the groups. So this is just more of the baseline data that I want to make special note of. So HDL cholesterol was approximately the same. The estimated GFR was 78 or 79, approximately the same. And Especially, I wanted to talk about their office blood pressure readings, which were essentially identical, 194, 190, or 149, excuse me, 0.4 and 149.5 over 86. 86, they're the same. Their sleep measures were the same. And their dipping status was effectively the same as well. So about 49% of these were non-dippers versus 51%. And if we'll recall, that on its own, dipping status is a risk factor, a protective factor for cardiovascular morbidity and mortality. Okay, so moving on. So our outcomes, like I said, was about 6.4 years. There was a minimum of 5 years of follow-up with a required minimum 1 year follow-up per patient. So the main outcome that was determined by this investigation was that the hazard ratio for all cardiovascular events, so all encompassing cardiovascular events as well as each of its components, including cardiovascular death, MI, revascularization, heart failure, and stroke, was significantly lower in the bedtime treatment arm, even when adjusted for all these other things that we consider to be risk factors for cardiovascular mortality. So that includes age, sex, diabetes status, cholesterol, prior events, a sleep systolic mean, and a sleep time relative systolic decline. And just of note, so greater benefit was seen in patients who this was their first treatment for hypertension, was that they got started on a nighttime dosing, and it was also the outcomes and the risk, the protective factor was better in patients who hadn't had a history of cardiovascular disease. And so that kind of makes sense in that in these patients who have not been treated and who have not had these adverse events, the horse has not already left the barn. We have a chance to help them. So these are the outcomes in a similar format by the numbers. There's a few things that I really wanted to highlight. So one was the number of medications that these patients were on by the end of these 6 years or so. So those who were in the awakening arm were more likely to be on more blood pressure medications and require more blood pressure medications than those who got the bedtime dosing. And this difference did reach significance. The serum creatinine of these patients who were on the bedtime dosing was lower than those who were in the awakening regimen. And for those of you who may not know, so our serum creatinine is a proxy of our renal function. And so this implies that the renal function is mildly better in those who get the bedtime treatment therapy versus those who get the awakening. We also see, two more circles. We also see that the HDL cholesterol, which is a protective factor for cardiovascular disease, is higher in those who had the bedtime treatment arm versus those in the awakening. And then in addition, our GFR, so another measure of our kidney function, is better in those who had the bedtime administration of blood pressure medications versus the awakening. And you'll see that the significance, the p-value between these groups, it approaches significance and is less than 0.001. Other things that I really wanted to highlight. So it may be well and good that we're seeing decreases in blood pressure asleep because we're giving medications at night. However, how do we know that our treatment's working if we're trying to do that? So what we'd really be seeing more often is the office measurements of people's blood pressure. And so there is evidence that suggests that even dosing at night, where we seem to be directly affecting that nighttime blood pressure primarily, we are seeing that demonstrated in our clinic patients. So in the office systolic, diastolic, and pulse pressure, we are seeing significant lowerings of all those measures in the bedtime group versus the awakening. And in addition, we also especially see the sleep systolic blood pressure mean decreased in the bedtime group, which we do know is a very tight correlate with cardiovascular risk. Cardiovascular risk. Okay, so a note on safety and compliance. So one thing that I know I considered and made me nervous when I thought about changing my patients to nighttime blood pressure medication was syncope or orthostasis. Are they going to wake up in the middle of the night and faint because their blood pressures bottom out? So in either arm, the awakening or bedtime group, only double-digit 39 and 26 patients respectively experienced sleep time hypotension. So that's about 0.3% of each treatment arm, and there's no significant difference, no apparent significant difference between those two groups. So it appears to be safe. And another question to ask is, are patients more likely or less likely to adhere to a regimen that's supposed to be given nightly versus in the morning? And adherence in either regimen was about 3% or so. So it doesn't appear to be any easier or harder to give medications at a different time. Some limitations to consider for this study is that this is a Caucasian Spanish population. So whether that can really be extrapolated or expanded to the San Antonio population, there's always a question of that, but I do think it's worth looking at. Another thing to consider that you may have noticed on some of the data is that the choice in blood pressure medications was not randomized. So doctors were able to have some freedom what blood pressure medications they would prescribe, and there were significant differences on which blood pressure medication was prescribed based on when they were supposed to be taking it. So for instance, calcium channel blockers were more frequently given at night, given to the nighttime dosers, whereas diuretics and hydrochlorothiazide, for instance, were given to the daytime. And the logic for that being that you don't want to give a diuretic at bedtime because people are going to get up and go to the bathroom and have disturbed sleep. So in order to explore this further, what would need to be done is randomizing the blood pressure medications as well. Okay, so a brief summary. Patients have better blood pressure control with bedtime treatment rather over awakening treatment. Either regimen is safe and it's likely equally manageable for our patients. Not only do we see actual blood pressure differences in these patients when they change their regimen, but it also does appear in the long run to reduce cardiovascular disease risk. And that's the whole reason that we manage blood pressure, is to reduce their long-term risk. And then just of note, something to consider is that decrease in asleep systolic blood pressure was the most significant factor for reduced cardiovascular disease risk. And it was a better predictor than our typical predictors such as age, male sex, low HDL, smoking, diabetes, and CKD. So that would make me consider, just as a side note, of if there's someone who I'm concerned about, I'm not sure about their diagnosis of hypertension. They come in hypertensive, we check it 5 minutes later and it's fine. It would make me consider doing ambulatory blood pressure monitoring and seeing what that tightest correlate is with their systolic mean sleep time blood pressure. So going forward, so I kind of answered this question a little bit in my previous slide. Is it worth reconsidering how we measure blood pressure in the ambulatory setting, especially given that we have better measures for cardiovascular risk than just the office blood pressure? And then another question is, if your patients are not having enough hypertensive effect on their current regimen, what would stop you from switching to the nighttime dosing? Is there anything that would make you more in favor of doing it or more against it? So just some questions to think about going forward. So overarching summary is that the relationship between the RAST system and the circadian rhythm can offer new avenues for antihypertensive management. And I would also say, in a broader sense, that looking at circadian rhythm, looking at our natural physiology and finding ways to use it to our advantage could be used in the management of a ton of different conditions. It probably not just hypertension. I think there's many opportunities to work with our physiology in terms of diabetes medications and a variety of other things. But overarchingly, simple, seemingly small changes in how we administer our medications can make a bigger difference than creating new drugs and creating new tests. Just change when you give the dose. So I know this is a really brief talk. It's kind of a simple paper. These are my references. I have the group chat open if anyone has any questions or anything they would like to share. I would really be happy to answer anything.
Hannah, I had a question. I know you covered it a little bit about about how the diuretics would be different. Could you go through that again? So would you recommend then that be given at night, or the other medicines given at night and that given in earlier in the day, or what's your recommendation on that?
So more work needs to be done as far as which medications are best for nighttime dosing. The reason why they didn't want to give that, probably we assume that people didn't want to give the diuretics at nighttime, is because you don't want to wake people up. And it appears to not make a difference what blood pressure medication you give, as long as you're giving them at night versus during the day. So and ultimately, just my personal preference, I tend to not like the diuretics, and I really don't like hydrochlorothiazide. Like, I think chlorothalidone works longer and is more potent, but I think there's other better antihypertensive medications than the diuretics that would be a better option. Does that make sense? Did that answer your question?
Yeah, it does. I was just thinking, when you're talking about all antihypertensives and it's totally up to the person's choice, I'm thinking, well, I'm not giving hydrochlorothiazide at night. I mean, because then
Right.
it's going to get up.
Right, exactly. So Dr. Hyan actually made a beautiful point that I didn't mention, but the number one drug started, the most common drug given to these patients was ACE and ARB, and giving them at night does not appear to have any create any issues for sleep disturbance, adherence, or safety. So I think Dr. Hyan initially at night and others during the day. So they didn't split up any dosing. So I think that would require a lot more further study. It seems that what we know now is working towards nighttime blood pressure changes is what can make the biggest difference. There's actually a lot of information on the physiology of blood pressure dipping and the science and the theory of why does that correlate so well. It seems to be like a rest period. And if we can target the RAST system, keep those renin levels down, which you may have noticed was higher in the hypertensive subjects, we can long-term, throughout the day, keep people's mean arterial blood pressure lower. Let's see, Dr. K, how do I unmute from phone? I don't know. You can maybe look at your phone and it probably
Yeah, I might actually be able to unmute him.
Okay.
Maybe not. It doesn't let me do that.
Is he on? Are you on a flip phone, Dr. K?
Yeah, it's not letting me.
That's okay. I'm not sure if I understand your question, Dr. Hyan, if you want to jump in and clarify.
Yeah, no, my point was that your initial presentation and rationale was the RAST system.
Mm-hmm.
ARBs and ACE inhibitors make a lot of sense from that perspective, but others, I'm not sure that necessarily fit that. And I suppose if you're trying to limit the therapy just to once a day, that makes sense to do it in the evening. But if you have and these were mostly patients who were not complex hypertensives, they only have 1 or 2 medications at the most. But if you have someone who has 4 or 5 medications for hypertension, it might make sense to then use the splitting, given that often they would include a diuretic that may affect their function during the day.
Yeah, I think that's an excellent point, which was not addressed because in this study, most of the people were on 1 to 2 blood pressure medications on average. So we didn't really get into those who had significant comorbidities, those who had like chronic kidney disease and heart failure and all those things were excluded at the beginning of the study. So this does favor a healthier, less difficult to control hypertensive. But I do think there's something to be said for having some of those doses given at night if you can make a difference for your patients.
Yeah, I just wanted to make a comment about just the format, because you'd mentioned it was a fairly straightforward study, but I just wanted to give a pitch that I think that that using these articles, these selected articles for grand rounds is a good format for us to discuss them in, a semi-disciplined fashion. So I appreciate you putting it together.
Yeah, no, I'm very happy to do it. I tried to stretch it out, but and give some background, but I'm very happy to give, I think it's an interesting topic. I'm very happy to.
The other issue, I'm sorry,
Yes.
the other issue that they came up in your presentation that hasn't been mentioned is that although it was a randomized trial, it wasn't a blind randomized trial.
No.
So the physicians actually knew whether they were morning or evenings, and so it was not truly randomized in that sense.
Mm-hmm.
So it
Right.
may,
So the medications they chose were not randomized. That's true.
not only that, but they didn't know whether they were day or night. I mean, they did know. They actually, the physicians actually knew, so they were not blinded to that.
No.
And that may potentially put in some bias in there as well.
Right. So they were blinded to the endpoints. They weren't sure what endpoints they were going to be studying, but they did know which timing they were given for those medications. And so there are some current studies by this same group that are looking into randomizing the blood pressure medications themselves. And I'm not sure if they're looking at randomizing the timing, because I think that would be very hard to do in a clinic setting when you're having such long-term follow-up. But yeah, I think that's one of the limitations of the study as well. Okay. If there's any other questions, please reach out.
Have there been any similar studies here, like in our Hispanic population or other populations here in the United States?
Are there other similar studies in our population?
Yeah.
Not that I've seen. Mostly, there's a few groups that it was a lot of European studies from what I saw, but I wouldn't be surprised if there's some more local groups looking into it. It's becoming a kind of a burgeoning field of medicine, is looking at how we can work with our physiology in order to have better outcomes. It's I think a more elegant way of solving problems than, constant doing new drug research or whatever else,
Yeah, excellent opportunity.
I think so.
Dr. Gadendall is making an excellent point about the study power and the difference between a statistical difference in clinical significance and statistical significance. I think that may be something you want to comment.
So let's see. Let me pull up his chat. Hold on. Look at the last table of results. Yeah. Right. Oh, okay. So you're saying that the difference between these, okay. Oh, that the difference between them. Right. So I think there's certain things that they have noted that there are differences between that are not clinically significant. I'm not sure if so my understanding is that the diastolic blood pressure, those 48-hour diastolic blood pressure means are not clinically significant. What was found to be clinically significant was the sleep time systolic blood pressure difference, and it did seem to correlate with cardiovascular risk reduction. Let's see the differences. Yeah, I mean, I think I see what you're saying, that even those numbers are small. Yes, there is a small difference, but I also don't think those are I don't think those are what we're going for or what we have found that makes the biggest difference. And really, these are drops in the bucket as in terms of the biggest difference between in cardiovascular risk reduction is treating the hypertension to begin with. So an untreated versus a treated, that's where we're going to see our biggest drop in risk. Changing the timing of the dose, I don't think we're aiming for huge differences. I think we're at the point of fine-tuning the risk reduction that we can achieve. understanding is that the diastolic blood pressure changes are not clinically significant. It's more of the systolic and the means.
But the main outcomes were clinically significant,
Yes.
meaning the risk reduction. And I think that's the big take-home message.
Yes. So am I answering your question, Dr. K? So I don't think that the 48-hour diastolic blood pressure mean difference is clinically significant, Dr. K.
I don't see a response from him again yet, so maybe you got him this time.
I don't know. He's a tough customer, huh?
Oh wait, here he's got
My
it.
point is that having too many subjects can be a problem. That's interesting. So I think, are you saying that we would need to look into like number needed to treat in order to decide whether making this change is worth it? So I think I think I understand what you're saying. So like how are you saying, like how many points drop in blood pressure is actually, I'm not sure if I understand what you're asking.
I don't know if this is his main point, but I think it does raise the point that the size of the study is important in your study design. Obviously, if you have 1 million subjects in your study, you might see a statistically significant difference, but then the study becomes too burdensome, too expensive to actually pull off in many instances. So when you're in the design phase, you certainly want to try to get some sort of a reasonable power analysis so that you know what size you need to study to get a clinically meaningful difference.
So he thinks there's too many subjects?
I can't speak for I don't know.
Okay, so I don't understand.
I think that is an important point is when you're designing a study, deciding how many people to put in it, rather than going, well, more is always better, more is not always better.
Mm-hmm.
Because then like I said, if you get too many subjects, your study become unwieldy, too expensive, et cetera. So you want to decide how many subjects you want in, what's a clinically significant difference if you can show it, and then size it to that amount.
I see.
I think there is some confusion here. I cannot pretend to know what Dr. Catterall is trying to say, but I think from my perspective, I think an important point is to emphasize the difference between statistical significance and clinical significance. In a study like this, you would need a lot of people not to look at those differences as much as it is to look at the stroke cardiovascular outcomes that they were looking for in 6 years. So I think that was a driver for the sample size. And these other changes are probably not clinically significant, but the fact that it made a huge difference or a big difference in terms of the outcomes that are critical and the reason why we treat hypertension, to me, that's the takeaway message. Otherwise, but I think that the teaching point here is don't be fooled by p-values, because p-values are dependent on the size of your n. If the n is, if you torture data long enough, it will confess. And here's an example of, it's not clinically significant, but it's statistically significant. I think that's it.
I see what you're saying. Okay, thank you, Dr. Hay.
Could you go back to the slide where you show the effect on the main outcomes? Did they actually report a hazard ratio?
Let me pull it up. I kind of have to get out of this slide. So if I pull up, if I pull something out of this, can y'all see my screen, or do you just see the slides? If I do this, can you still see the same thing?
Yeah, we're still seeing the same slide.
Okay,
Yeah,
great.
slide.
So hold on just a second. Okay, so we have, I can pull up the hazard ratios. I should have put these in, but I did not. So the hazard ratios for primary CVD outcome, do you want me to read them out, or do you want me to pull? I can actually pull them up somewhere. Let's see. Let's see how I can change this new sharing. Okay, so I have the hazard ratios here. So primary CVD outcome was 0.55 with a confidence interval of 0.5 to 0.61. Each of its single components: cardiovascular death 0.44, MI 0.66, coronary revascularization 0.6, heart failure 0.8, and or 0.58, excuse me, and then stroke 0.51. So these were the risk of these were reduced by half approximately.
Do we have anybody else with any further questions? I see Jordan put something on the chat here.
Oh, I didn't see it. No, they didn't control for, they did not control for medication prescribed. They, no, they did not. So wait, can you see the slides, or can you see the risk reduction? Can you see the, or
Right
no,
now
maybe
we're seeing your screen. It's not
the
the
web page.
the article, yeah.
Cool. Okay.
Okay, we will probably end the presentation here then. If anybody has any further questions, as Dr. Korman mentioned, you can email her, or if you need help with anything else, please feel free to email me as well. And also don't forget to fill out the evaluation for her. So we want to thank everybody, and thank you, Dr. Korman. And
Thank you. Yeah. Thank you everyone for having me and being good audience members.
Thanks, Anna.